Now we move on to another topic that has engaged a lot of the efforts of Better Health Partnership over the past year plus, addressing climate change in health. I mentioned that this has been a focus of our Health Metrics Advisory Committee that really is focusing on bridging the gap between understanding the data surrounding the social determinants of health and the impact on health, and choosing the topic of climate change in health has been fairly obvious as to the need. Rich supplies of data in both spheres, but bringing those together has been a tremendous challenge. So to start us off in this conversation, I'm delighted to be able to introduce Dr. Ash Sehgal. He's Director of Research and Evaluation, the Institute of Hope, co-director for the Center for Reducing Health Disparities, and the Duncan Neuhauser Professor of Community Health Improvement at Case Western Reserve University through the MetroHealth System. Dr. Sehgal.
Good morning, everybody. Let's go ahead and go on to the next slide. So there's three ideas I want you to take away from this presentation. The first is that health systems will have to deal with the health impacts of climate change. The second is that health systems themselves are contributing to climate change. And the third is that the quality improvement approach that Better Health Partnership uses might be able to help us with both of these challenges. Next slide. Here are the things I'm going to cover in my presentation: the mechanisms of climate change, the health impacts of climate change, what we're doing in our Northeast Ohio health system collaboration, and then some final thoughts. So our health system collaboration includes both a physician and an energy manager from these 5 health systems: MetroHealth, Akron Children's, Cleveland Clinic, the Cleveland VA, and university hospitals. Next slide. So here's a simple way to think about the mechanisms of climate change. So we have solar energy that comes in from outer space and is absorbed by the Earth's surface. That's indicated by the large orange arrow in the diagram. But then some of this solar energy is radiated back towards outer space. That's the middle orange arrow in the diagram. Now the key here is that that radiated solar energy is radiated at a longer wavelength, at an infrared wavelength, than the incoming solar radiation. And unfortunately for us, carbon dioxide and other greenhouse gases, such as methane and nitrous oxide, absorb some of this infrared energy and therefore limit the radiation back to space. So the net result of all this process is that the temperature of the surface of the Earth increases. Next slide. Now there's an urgency about this climate change crisis because carbon dioxide levels have increased from 280 in pre-industrial times to 413 now, so quite a sizable increase. And experts say that to limit the substantial further increases, we need to cut our carbon emissions, our carbon dioxide emissions, by 50% in the next decade, and to be carbon neutral by 2050. In other words, not having any net addition of carbon dioxide to the atmosphere. Next slide. So that's a bit about the mechanisms of climate change. Now let's talk about the health impacts of climate change. Next slide. These are some of the major climate hazards due to climate change: increased temperature, wildfires and air pollution, storms and floods, and droughts. Next slide. So the increased temperature that results due to climate change can cause dehydration, fatigue, heat stroke, and kidney disease, among other problems. And this is especially a problem. This is especially a problem for people who have to work outdoors in hot weather, such as these farmers in this picture. Next slide. The higher temperatures also increase wildfires, mold, pollen, and other pollutants, you wouldn't be surprised to learn that air pollution results in increases in asthma and allergies. But it turns out that air pollution also is a significant contributor to cardiovascular disease and mortality. Here's a photograph of a recent wildfire in Australia. Next slide. Now, the warming that results from increased temperatures increases evaporation, which results in more storms and floods and more severe storms and floods. This is a photograph of Hurricane Maria as it was approaching Puerto Rico. This hurricane resulted in many injuries and deaths and adverse effects on mental health. Next slide. Now, the increased temperature and the increased evaporation causes storms and floods in some areas, but causes droughts in others. These droughts can reduce freshwater supplies and agricultural production, which lead to malnutrition and diarrheal diseases. Here's a photo of a drought affecting a cornfield. Next slide. So all of these health hazards are going to have an impact on healthcare systems because they're going to change the prevalence and the geographic spread of illnesses. Extreme weather can also disrupt utilities, transportation, and communication systems. This is a photo of a hospital that was flooded due to Hurricane Katrina. Now, not only will healthcare systems have to deal with the impacts of climate change, it turns out that they also contribute to climate change because they emit substantial amounts of greenhouse gases. In the US, it's estimated that 10% of all greenhouse gases come from the healthcare sector. Next slide. Let me tell you now a little bit about what we're doing in our health system collaboration. Next slide. So the 5 health systems that are in our collaboration are doing the following things. We've begun to share our energy use data, and then we hope to use quality improvement methods to try to understand and reduce our carbon footprints. Next slide. Here's an example of the data that we're sharing. This slide shows the emissions related to energy use at our 5 health systems. And you can see that the numbers vary from 21 to 24 metric tons of carbon dioxide equivalents per 1,000 square feet of building space that were emitted by our health systems in the year 2020. Next slide. We're also looking at where the energy emissions are coming from. This is one of the health systems, but the other health systems had very similar results. So in terms of greenhouse gas emissions related to energy use, about 2/3 of that comes from electricity and about 1/3 comes from natural gas. Next slide. We're also looking at changes over time. This is what happened to our energy-related emissions from 2019 to 2020. And you can see that there were either small decreases or small increases in energy-related emissions at our health systems from 2019 to 2020. Remember, I said earlier that our goal should be to cut emissions 50% by the year 2030. To reach that goal, we need to have a 7.5% decrease year over year. In other words, 2021 needs to be 7.5% lower than 2020, and 2022 needs to be 7.5% lower than 2021, and so forth. So you can see that compared to what we need to be doing, what we're actually doing is not as much. Next slide. Here's what we plan to do next in our collaboration. We plan to identify best practices to reduce energy use. We plan to examine emissions related to supplies and services, and we plan to help our health systems prepare for climate-sensitive health conditions such as asthma, COPD, and allergies. Next slide. And then I'll conclude with a few final thoughts. So when you think about the health impacts of climate change, I want you to keep this diagram in mind. So we're burning fossil fuels. That releases carbon dioxide into the atmosphere. That results in climate change. Climate change creates hazards such as wildfires, and those hazards have health impacts such as asthma. Next slide. Now, in the context of climate change, the term mitigation means doing something to reduce carbon dioxide emissions. So for example, if we got our electricity from solar and wind instead of from coal-fired power plants, that would reduce our carbon dioxide emissions, and that would be an example of mitigation. In the context of climate change, adaptation means trying to adjust to the effects of climate change. So for example, if we told our asthmatic patients to stay indoors when the outdoor air quality was bad, that would be an example of adaptation. And of course, we all know what suffering means. And our future is going to be a combination of these three things: mitigation, adaptation, and suffering. What we don't know is how much of each of these three things are in store for us in the future. And it's important for us to work as hard as we can to focus on mitigation and adaptation so that we can limit suffering. Next slide. If you're interested in this topic, I'd suggest that you pick a climate hazard or a health impact, review what's already been done in that area, and then decide where you can contribute. You might want to educate the public or policymakers or health providers about this topic. You might want to implement programs in your practice or your health system. You might want to conduct research to address gaps in our knowledge. And most important, I think we all need to, as citizens and consumers, to push our governments and our corporations to dramatically reduce our society's carbon footprints. We actually already have the technology to do this, and the cost of energy from renewable sources is now already either comparable to or cheaper than energy from fossil fuel sources, but we need to have the political will to make these changes. Next slide. Here's my final slide. Here's some resources that might be helpful to you. There's an organization called Ohio Clinicians for Climate Action, which is doing a lot of great work in this area. There's a new journal called the Journal of Climate Change and Health that I'm on the editorial board of. It's a free online journal that you can access easily online. There are 3 newsletters that I recommend. You can Google these names and sign up to receive an email once a week or every few days from these sources that'll help you keep on top of the latest developments. And then I have my email address there. If you have any questions or if there's anything I can help you with, feel free to contact me. And with that, I will turn it back over to Don.
Thank you so much, Ash. Thanks for spelling out the concern so clearly to us. I'm going to move on to our next speaker. Hopefully we'll have time at the end for some questions. If you can stick around, Ash, see if anybody has any questions. Now I get to introduce Sarah O'Keefe, who's the Director of Sustainability for the MetroHealth System.
Thank you. Hi, everyone. I'm so grateful to be here as a part of the Learning Collaborative today, and especially thanks to Ash Sehgal for bringing the Northeast Ohio Health Systems and Climate Change Group together through the Better Health Partnership, and thank you also, Rita, for your leadership there. I am excited to be a part of the Learning Collaborative today and to share a resource that I think other healthcare anchor institutions or healthcare organizations might be interested in. Next slide, please. This resource comes from Practice Green Health, which is a national sustainable healthcare organizations that hospitals and healthcare institutions belong to. It is basically a tool that connects our health and our energy use. Ash spoke a lot about the fact that healthcare institutions need to deal with the health impacts of climate change, but also emphasized, of course, that we ourselves as healthcare anchors and healthcare systems are contributors to climate change. And I find that a very empowering fact, because that means that we have a lot of potential impact, positive impact on climate change. So these are talking points for healthcare anchors that are really seeking to take action on climate and health. Next slide, please. Digging a little deeper, Ash mentioned that 10% of greenhouse gas emissions are in the healthcare sector, with over 1/3 of those emissions actually coming from hospitals themselves. And this is one kind of cost, right? We are talking about the climate emissions and the cascade effect and those health impacts down the line. But in addition to that, we are also have a financial and more immediate costs in terms of air pollution. So we use, as hospitals, actually healthcare sector spaces, use 2.5 times more energy per square foot than an office building of the same size. And annually, we spend about $9.5 billion on energy each year as a healthcare sector. So as we contribute to both decreased air quality and climate change as a large energy user, we can think about our decisions on energy in terms of our health mission. Next slide, please. Here you have a graphic that's rather small. I apologize for that. But if you'd like to delve deeper into it, it's at healthyenergyinitiative.org. And it shows not only the cascading effect of climate change, but this specifically looks at energy production and how the environmental disruptions from energy production, such as extraction, transport, processing, distribution, and waste disposal, cause environmental disruptions, such as air emissions, air pollution, water use, land use, and eventually trickle over to the human health outcomes, life expectancy, quality of life, physical and mental health, and of course, health equity. Now, the cleanest form of energy that we use is that the unit that we reduce, right? So the cleanest form of energy is energy not used. And when we think about our energy choices, as Ash already mentioned in this collaborative, we're thinking about reducing opportunities to reduce our energy use, reduce the immediate health and environmental impacts of energy production, but also that cascading effect of climate emissions. Additionally, of course, we have, depending on the margin for a nonprofit healthcare organization, for every dollar that's not spent on energy or that's saved on energy is equivalent to generating at least $20 in new patient revenue, which helps us, of course, on the financial side, but also we can divert those savings to patient care, ultimately. I want to just go a little bit more locally. Next slide, please. And think about energy and our health and energy health decisions related to a more local scenario. So in Cuyahoga County, we have some population statistics here that I pulled from the American Lung Association. And these are related to diseases related to air quality. We have the county population of 1.2 million, and then we have various demographics, youth under 18. These are counts of individuals, elderly over 65, those with poverty, and people of color, alongside of the number of individuals that have pediatric and adult asthma or COPD, lung cancer, cardiovascular disease. And we want to think about this context as, for example, healthcare institutions who might have service area in Cuyahoga County. Go ahead, next slide. And this ties, of course, to our own assessment of community health needs in Cuyahoga County. If you can see the 5 priority areas that were the focus for 2019 through 2022, I'd like to make the connection between at least 3 of them specifically to energy use and decisions and thinking about health. So we have reducing chronic illnesses at the bottom and its effects. We already heard about asthma, COPD, and cardiovascular disease, and the use of energy production and climate change and the impacts on air pollution that can impact these diseases. But we also heard a lot today about enhancing trust and trustworthiness across sectors amongst people and in our communities. So this is anchor mission resonant, right? As large energy users, as healthcare anchor institutions, we have that potential to have a large impact. And of course, on eliminating structural racism, we know that Black people, Indigenous, and people of color individuals are more often exposed to air pollution in their communities due to various factors that we've all learned about today or discussed today. Next slide. So while we have the context of what the impacts are on health when we think about energy use and the health impacts from the energy production, and eventually the health impacts that come from climate change because we are using fossil fuel generated energy. It helps to think about another way to quantify those. How do we quantify them? Until recently, there wasn't really a great tool for this, but Practice Green Health has a tool called the Energy and Health Impact Calculator. I'm just going to go over fairly briefly how it works because I don't want to get into too much detail, but you can go to this website, you can download it even if you're not a member. If your healthcare organization is not a member, you can download it and use it. Basically, you download the tool, it's an Excel spreadsheet. You input energy data for your health system or healthcare anchor building, and then the energy data is converted to emissions results. And that those emission results are then use various resources listed below here on this slide to calculate the health and welfare impacts of those emissions. And then those health and welfare impacts incidences are assigned a value based on a lot of different studies and research that you can find as a part of the tool. And you ultimately get results as a user, and you can use these results in discussions with your peers, with your senior leadership at your healthcare institution, for example, to think about how you want to impact, take perhaps action on energy use efficiency and maybe the kind of energy that you're using. Next slide. So in this example, hospital that Practice Green Health has in its tool, if you were to download this tool, you would see this is one of the outputs. So this is a total health results table. It's basically taking all of the energy, quantifying incident values and incidents per year in these various categories like premature death, hospital admissions, asthma exacerbation, respiratory symptoms, non-fatal heart attacks, ER visits, but also in the social costs of carbon, work loss and restricted days, and incidences of mercury-related incidences. Ultimately, the quantification for this hospital, which uses fossil fuel generated electricity, was about $42 million socially to society, the cost to society. The direct medical costs were around $173,000. So due to dispersal patterns, there's a note here, social determinants of health and other environmental health factors, these health impacts and costs of emissions cannot really be attributed to a given location or population. I can't say this is exactly happening in Cuyahoga County because our energy that's generated, for example, our electricity might not be generated in Cleveland, Ohio. It might be generated in Indiana or Pennsylvania. However, even though we can't ascribe the impacts to this specific geography, our healthcare mission really doesn't have a geographical limit. So I think that's an important thing to note. Next slide. And just to emphasize Ash's earlier point, you saw that at 65% of the emissions that come from an area, one of the hospitals that we are part of our group, 65% of the emissions come from electricity. In this case as well, for a fossil fuel generated electricity, this hospital, 85% of the total incident value for its energy use comes from the electricity side. And this is because it's fossil fuel generated. I think that's a very important point, was we look to take action and electricity becomes an opportunity. Next slide. Meanwhile, delivered fuels like natural gas, fuel oil, diesel oil for backup generators is a much smaller portion of the overall quantification of this incidence. Next slide. And here you can see it side by side, basically the total incident value when you compare the emissions from electricity versus the emissions from delivered fuels and the value of those incidents. So purchased electricity really becomes a great value opportunity. Next slide. And this is the actual emissions from the energy that was put into this calculator. You can see here the inputs were on electricity and natural gas for this particular example, but you could also input fuel oil, distillate number 2, number 4, number 6, and then propane, district steam, coal, if you burn coal still in your utility plant, for example. I think most of ours use natural gas now, which is great. So these show the emissions, but it also shows you the equivalency of these emissions as if more in layman's terms, if you would. So the emissions for this hospital, for example, are equivalent to 1.4 gallons of gasoline being consumed in a year, or the power of 2,000 homes electricity use in 1 year. So that kind of puts it into terms. So what do we do with this kind of information now that we know, for example, electricity and energy use has these kinds of impacts? Next slide. There are, of course, lots of opportunities, but again, going back to one of our first points, and Ash mentioned it as well, decreasing energy use first is really one of the primary steps for decreasing emissions, both in terms of contribution to climate change and also air pollutants. So John Utech, who's next, is going to talk a lot about a specific example and case study and go into detail on the opportunities there and what they look like in real life. And then I think after energy efficiency, it's important to talk about, especially in this particular case, renewable electricity as an option. When we see electricity contributing to all of these different emissions, then it becomes an immediate opportunity. There are lots of different ways to achieve that, of course, and there are lots of different goals to join, or both regionally, locally, and nationally. And I will just tell you that when we put our own MetroHealth's energy usage into this calculator, we saw that if we were to convert 50% of our electricity, not energy, I should say electricity there, 50% of our electricity to renewable, we would see a 40 to 50% reduction in the incident value of those health results that this calculator shows. So it's a very exciting kind of tool. It's very actionable and tangible to have in discussion. And it's more of a conversation starter than an endpoint. But I just wanted to share that with the group today. Thank you for your time.
Thank you so much. If we can move on to the next slide, I will now introduce John Utech, who's the Senior Director of Sustainability for the Office of Sustainability, Buildings and Design at Cleveland Clinic. John?
Thank you. Next slide, please. I'm going to start with thanking Ash and the Better Health Partnership for organizing what I think is a very, forward-thinking and national leading partnership around sharing sort of carbon as a quality improvement opportunity within Northeast Ohio and beyond. Ash framed it at a high level. Sarah did sort of talk about the health impacts. I'm going to share a couple ways that I frame this within my organization, and then share some examples of work we've done to reduce and minimize our carbon footprint. So one way that I talk about it is that sustainability, broadly speaking, is responsible. Air pollution, pollution of water and soil is responsible for about 1/4 of deaths globally, according to World Health Study in 2017, and 10% of US deaths relating to the built environment and environmental quality, according to a study done in Wisconsin. Next slide, please. So our office was founded in 2007, and through about a decade's worth of work, we built up to the point where Cleveland Clinic committed to a carbon neutral goal in 2017, building on success in energy efficiency and realizing the impact and importance of climate to human health in Ohio and to the world. Next slide. And really, I created this about 2014-15 timeframe to think about and communicate different strategies that different healthcare systems can use to think about climate change and the effects that they can have. This is adapted from a model from the IPCC, but really the concept here is that human interference is causing climate change, as Ash talked about, which is causing all different kinds of impacts and vulnerabilities. And really, we as healthcare systems can mitigate our own footprint, reducing the cycle. Some level of change is already inevitable, so we need to plan for adaptations to different vulnerabilities and impacts, both for our patients and for the operation of our healthcare systems. We need to change the way we're practicing medicine to account for the health impacts that we're seeing present right now. And then there's also the possibility that we can advocate for policies that would accelerate all of these things. Next slide, please. So we have a number of people, including Dr. Ford and others, have talked about the importance of partnerships. This slide is just to highlight some of the really important partnerships that we've had at Cleveland Clinic to work on mitigation, adaptation, advocacy, and the clinical impacts. That's why I was so excited of the Better Health Partnership So it's a very localized way of working on this, but we work with Department of Energy, Health and Human Services, Healthcare Without Harm, UN Global Compact, Ohio Hospital Association. There's lots of collaborative groups that are all taking different pieces and parts of this. Really, the only way that we solve this problem is through collective change. Next slide, please. So don't want to go too deep on this one, but just to talk a little bit about what a carbon footprint is, because not everyone knows what it is. And I have the inevitable distinction of being trained as a carbon accountant back in 2008. So they divide emissions into 3 scopes, depending exactly on who really, different types of ownerships of those emissions. So scope 1 is you own an asset that emits greenhouse gas. And in healthcare, that is typically things. In Northeast Ohio, we burn natural gas to create steam and heat our buildings. We own vehicles that combust fuel. There's refrigerants, and actually the anesthetic gas that we use in surgeries are greenhouse gases as well. Next slide. Scope 2 is someone else owns the asset, but you're sort of directly responsible for the usage of that within your building. So that's purchase electricity, purchase steam, or chilled water. We buy and other healthcare systems in this collaborative, in the partnership, purchase energy from the grid in Ohio. We don't own the power plants, but we use the energy and we can control that. That's scope 2 emissions. Next slide. Scope 3 is everything else. Everything else is a lot. It's everything we buy. It's the investments in our endowments. It's all the building that we make. It's commuting. It's sort of a whole host of issues. And I'll talk a little bit more about that in a minute. Next slide, please. So within Cleveland Clinic, scope 1 is about 25% of our footprint. Anesthetic gases are 2%. Burning of natural fuels and gasoline and diesel fuel, 23%, and then the rest is electricity. Next slide. We have been working with Healthcare Without Harm and I actually worked with Healthcare Without Harm to create a tool to calculate carbon footprints. Done the same thing with the Better Health Partnership, and there has been work to develop a scope 3 tool. So I'm sharing this just to sort of give you a sense of the relative magnitude of things. These are 2 different systems that we're in a pilot group. Cleveland Clinic is one of them. The blue bars are purchased goods and services. The green bar is investments. Red is capital goods. This is commuting. So really the top 4 are the things we buy, the investments we make, our construction, and then commuting. And then there's a bunch of other things as well. Next slide. So in the time left, I'm going to primarily focus on things that we have done at Cleveland Clinic to reduce our footprint. As Ash mentioned, this week at the Communication on Progress in Glasgow, there's a talk about how do we accelerate progress towards getting to net zero. And there's been discussion in a lot of groups about getting to a 50% reduction in carbon footprint by 2030. As Ash said, we're going to need to accelerate progress. So one point of discussion within the partnership is going to be some of these items, because as Sarah said, the best energy you can use is the one you don't use. So getting rid of energy in the first place is sort of the first step in the solution. And here at the right are strategies that Cleveland Clinic has implemented across its whole enterprise, about 20 million square feet of buildings. And we reduced our energy usage about 26% from 2010 to 2020. Next slide. We've actually partnered with the DOE at the national level on this topic, along with other healthcare systems that have made this commitment. And for those reporting their reduction, Cleveland Clinic had the highest reduction of any healthcare system in what the Department of Energy is calling the Better Buildings Challenge. Next slide. So that's all really good. And if you look from 2000, in this chart, the big bars is Cleveland Clinic's enterprise carbon footprint. The red line is our intensity on a per square foot basis. So the amount of real estate we've had has grown a bit. So we've actually taken our intensity down 23%, while our total footprint is down 25%. And if you look at the drivers of that, energy efficiency is the biggest part of it. More fuel efficient vehicles is another part. Anesthetic gases is another. And then the green has become greater as well. But as we look out to reaching our goal by 2027, we definitely need to do more efficiency. We need to build better buildings. But we do need to, as Sarah was talking about, part of there are limitations to how far healthcare systems can reduce their energy usage based on just the acute needs for energy in a building and the regulations that bound that usage. So certainly sourcing renewable energy is going to be part of that solution. Next slide. So just in the continuous improvement mindset, this is a Pareto chart of the sources of the reduction in 26%. The biggest contributors to our reduction were when we built better buildings, we built them more efficiently than our predecessors. And I know other healthcare systems are building new buildings with that in mind, but that's actually the biggest thing that we did towards this is just when we built new buildings, we built them better than their predecessors. We upgraded the biggest LED lighting retrofit in all of healthcare. We use less energy on our operating rooms and labs. We put energy efficiency thinking into our equipment upgrades. We encourage better behavior. And then we just turned a bunch of things off and retro-commissioned equipment. Next slide. So we have, Cleveland Clinic's built 18 different buildings that have achieved LEED certification, which has energy as a fundamental component. There's just a list of what some of those are. Next slide. This is one that I think could be a really interesting collaboration point for better health is, and I think there already has been some collaboration on this topic within Northeast Ohio, but LED lights have become cost effective, payback is quick. And so we started a project in 2014 and now within Cleveland Clinic reduced more than 500,000 cans and tubes. As part of this, tried to have a social impact in that two of the businesses we used for these retrofits were diverse, one female owned, one minority. And we procured some of these things actually made in Northeast Ohio. So, this is in terms of reducing energy impact, we can have some social impact as well through manufacturing and installation job creation. Next slide. Then I know there's a number of clinicians online. There's very strict regulations that regulate the usage of energy within a healthcare building. So we optimize the usage of that energy. In certain buildings, we were exceeding the guidelines by forming a Green the OR committee and getting surgeons, administrators, and nurses to support this. We implemented a program to meet those guidelines, saving $2 million and reducing our energy footprint. Next slide. And we did that by, putting monitors in rooms where this was taking place so that people could see that while when buildings weren't being used, using less energy, they were kind of in range when those operating rooms and labs and procedure rooms were being used. Next slide. And we have put in, systems to give our facilities engineers visibility on all the different things that we're doing from an energy perspective. Next slide. So in terms of, what can hospital administrators do? What can physicians and nurses and all those that occupy all different kinds of healthcare buildings across Northeast Ohio? Behavior is a big part of how we can impact energy. Certainly there are buildings where, the request of a senior doctor or a certain important person causes a whole building's energy usage to change based on trying to cool a small space within one room. So we've done all kinds of communication around keeping buildings within temperature ranges, removing space heaters, using clothing to modify temperature as opposed to using the thermostat. So everyone who's in a healthcare building every day can make a small contribution towards our climate goals by complying and helping with this kind of behavior. Next slide. We worked with our EHS to create space heaters become very controversial. And sometimes people are chilly, so We actually went to the length of declaring space heaters an unauthorized appliance so that people that are going and doing walkthroughs can actually remove those and from our buildings. Next slide. And then we try to use humor and sort of make it a bit fun in terms of, temperature can become a very controversial thing. So having leadership at the high level and ground level supporting the work is fundamentally important for success. Next slide. We've created an energy training. So any caregiver who joins Cleveland Clinic gets a training on the importance of our energy goal, the health impacts, and training on the behaviors that I just identified. We published a case study on this through Healthier Hospitals Initiative that I can share. So that, because reaching our 70,000 caregivers is challenging, so we've actually built it into an online training environment to try to educate people on how to do this. Next slide. And we do different outreach events, Earth Day, lab, we have a thing called Labapalooza to also educate everyone the role they can play in reducing energy and carbon footprint. Next slide. Another action point for healthcare systems is improving vehicle fuel efficiency. So we've made a commitment to use vehicles and purchase vehicles that use less gasoline. This conversation is evolving to buying electric vehicles as opposed to just more fuel efficient gasoline and diesel cars, but we have in the last decade improved vehicle fuel efficiency by 44%. And this is miles per gallon, 2010 to 2021. Next slide. And then anesthetic gases. So for those involved in the different aspects of healthcare that have surgery, we've reduced our anesthetic gas footprint, which is down to 2% of our total footprint, 31% in the last decade. We eliminated desflurane, which is a very potent greenhouse gas, and we've implemented low flow things to reduce the amount of anesthetic gas administered to patients, keeping them clinically safe, but using the appropriate amount of anesthetic agent. Next slide. And then finally, Sarah touched on this. So we, proud that we've done good work, very, very excited to collaborate about the ways that we can implement these kinds of energy efficiencies across Northeast Ohio. And then there's additional collaborative opportunities around procuring on-site renewable energy, off-site renewable energy, which is procuring from large systems or other types of buys. Other options are purchasing renewable energy credits and carbon offsets to try to mitigate our footprint. And then finally, we can engage our suppliers in the ways that we procure. There's a very interesting body of work unpacking the carbon impacts of different drugs or different procedures. And a number of physicians are leading the way in terms of arming our caregivers with how the choices they make on a day-to-day basis can impact the carbon footprint of healthcare. So very exciting, expanding group of space that really impacts all of you on the call. And I'm happy to share some of just a case study of some of the opportunities that we see today. Next slide. And that's it for me. Thank you very much.
Thank you, John, and thanks to all of our presenters on this really important topic. I'll just note that you were able to trim 7.5% of the time of this presentation from what was allotted. So I think we're on our way to zero net growth in terms of the length of our learning collaboratives. I would invite any questions in the chat. There's so much here. Boy, this seems like such a vast problem, and yet you've all demonstrated that there are ways that we can actually make impact. As a clinician myself, I might turn this back to Ash and just see if you can comment on the idea that you brought this up, and we talked about this in one of our health metrics advisory committee meetings about this idea of how do we prepare our patients for climate change. We need to address climate change. We need to address it ourselves in our organizations and on our own carbon footprint, whether it's at work or at home. We can't act as if it's not something that our patients are dealing with. Can you say a little bit more about that from the clinical side? What are the approaches that we can take to really strengthen, improve the resilience of our patients in the face of what we understand to be happening around us?
Yeah, that's a great question. So I think if a patient has a climate sensitive health condition like asthma or COPD or allergies, then there's two things that clinicians should do. One is that they should educate patients about the link between climate change and their health condition. And then the second thing they should do is talk to their patients about specific things that the patients can do to help them adapt to the effects of climate change. So in the case of asthma, it might be teaching the patients how they can look up what the air quality is like on a particular day online, and then what they might want to do in terms of staying indoors or wearing a mask if they go outdoors, or being extra cautious about exercising. So I think that there's two areas. One is educating them about climate change in general, and then second is thinking about specific things that patients can do to reduce the impact of climate change on their particular condition.
Thank you so much. I'll read a question from the chat about this from Lauren Anthus. How do systems manage food waste? Have you partnered with local organizations, e.g. Rust Belt Riders, to manage your food management in a cyclical way, procure from farms who use the compost from your waste, etc.? That might be something that John or Sarah could address.
John, go for it.
So Rust Belt Riders is a partner of ours in some, candidly, not all of our hospitals, but interestingly, they were funded by, there's a group called Cleveland Climate Action Fund. So they got some seed money for some of their work from a local climate action fund. That's just another cool little story, but they have grown up and they're incredibly capable composted food. So at our main campus, we use Rust Belt Riders to compost our food waste. And we do purchase back the compost. We do tree plantings. That's something I didn't talk about, but we actually use that composted food waste in planting trees in the Fairfax and Huff communities in the last year.
And on the MetroHealth side, we have partnered with Rust Belt Riders to run a pilot program for composting out of our kitchen area. And we're looking at that and seeing if we can scale it up potentially with Rust Belt or another provider when our new hospital tower is completed with our new kitchen, et cetera. So stay tuned.
Thank you. There's been appreciation in the chat also about the participation of the 5 health systems in the work that's being looked at here. We have a number of different organizations represented in our audience today. I am impressed at the dedication of these healthcare anchor institutions to not only address these problems, but to make sure that there is staff, that there are professionals who are working in these areas and addressing these problems. Do you have any thoughts for other organizations about how they might be able to establish departments or parts of their organization such as you have?
I'll take this first. So I love this question. I think when I first came in, I'm the first director of sustainability for the MetroHealth System since January of 2018. And when I arrived, everybody said, "Oh, you can do sustainability." And I was like, "Oh, it's not just me." So I think that's the first start, is that even though I have the designation of director for sustainability, I have convened an interdisciplinary sustainability advisory council from across, and then a few members are actually on the line today and we're presenters today. And I think that is a first step that can be taken by anybody in the health system, and getting decision makers, frontline workers, also operations folks, but also clinical leaders on that advisory council is very important to figure out where you can prioritize. There are many ways to address things like climate change, from food waste to energy use to transportation, and keep going. So I think that figuring that out is is a great way. Having a group to help figure that out is a great way, and to eventually promote the idea of having a sustainability assigned director or whatever it might be, which is how it came about at MetroHealth as well.
Yep, I'd add, if you're in a healthcare facility that doesn't have a dedicated team, start a green team in your facility. Find some people interested in this topic and just start something. We operate green teams in our hospitals and family health centers in Northeast Ohio. They vary a bit in size and intensity depending on sort of waning and waxing of interest in different, but we do have that structure in place to support that across Northeast Ohio. But I'd start with just finding some other people interested, start a green team. In terms of the case for doing this work, Practice Green Health has some great tools to sort of make the case. But in general, it's young people entering the workforce have expectations that organizations are doing this of any kind, be they healthcare organizations or any other kind of manufacturing. Competition for jobs has never been fiercer. So I think this is a really important recruiting tool if you're talking to leaders in your organization. And then, there's financial benefits to this. Certainly energy efficiency has saved Cleveland Clinic almost $100 million in the last 12 years. So there's parts of this that can impact the economic part of an organization's. So that's a part of the justification. And then there's a community health impact. So there's kind of different ways that, depending on the leadership team and what they care about, that you could pitch this to an organization if you're in one that does not have this kind of resource.
Terrific words. Thank you. Yeah, I've been aware, we've been having green teams locally in our clinical practices for the 20 plus years that I've been at Cleveland Clinic. And they're still in existence and they're still acting locally, but how much more powerful to have this umbrella of organizational energy to move things forward. Terrific work. I thank all of you for your efforts, for coming and joining us today, and look forward to our ongoing work together and however we can continue to address these significant problems that we're all facing as human beings on planet Earth.